And I'll introduce Rhonda as she is the stroke best practice clinical nurse specialist at Hamilton Health Sciences. She supports teams within Hamilton Health Sciences and the Central South Stroke Network to implement best practices for stroke care across the region. And Steph Pagliuso has worked in stroke care for over 50 years and as the stroke navigator for Hamilton Health Sciences and as part of the regional stroke network as the rehab coordinator and community coordinator, and now as the regional stroke director. Okay, handing it to you guys.
Thanks, Tina. Steph's going to share our slides. And so I'm going to start. We're going to talk a bit about stroke distinction, and as we are going forward with that in May of 2025 at 3 of our centers, and we'll share a bit of data with you as we're going. So the Stroke Distinction Program is a program through Accreditation Canada that is really meant to recognize evidence-informed best practices, and the site surveyors will evaluate organizations based on 5 components. You may say, well, why would you undergo stroke distinction? It really is to recognize the excellence in provision of stroke care across the region. It really is to recognize centers of excellence. It really allows organizations in our region to reflect on where we're at with implementation of best practices and identify opportunities for improvement, really to engage the clinicians working in stroke care, and really to celebrate the amazing work we do every day that support implementation of best practices. We'll talk about some of the hyperacute best practices, and we sometimes forget that really the work we're doing every day in stroke is best practice, is excellence in care, and it really allows us to go back and celebrate that. Certainly, by implementing best practices, our goals are really to improve the outcomes for stroke patients and their families within the region. So when you look and see who's going through stroke distinction, the Central South Regional Stroke Network is undergoing distinction and really looking at how do we coordinate and plan implementation of best practices. Grand River Hospital is moving forward with acute stroke services and inpatient rehab. Hamilton Health Sciences, the Hamilton General site, is moving forward with acute stroke services and inpatient rehab. And our 2 hospitals in Niagara, so Niagara Falls, Niagara Health, Niagara Falls site is undergoing for acute stroke services, and then the Hotel du Shaver for inpatient rehabilitation services. When we then move forward, it is what are the best practices? So the first component is standards. There are 3 sets of standards that will evaluate the delivery of high quality care. One of those is acute stroke services, and the acute stroke services covers the pre-hospital, the hyperacute phase within the emergency department, and the acute stroke services. There's inpatient stroke rehabilitation, and then providing a system of care for persons with lived experience. What I'll do is review some of the standards that are really applicable for you in the paramedic services. So next slide. The first one looks at how do we identify partnerships and collaborate with other service providers and organizations, including acute organizations and emergency services, to coordinate, plan, and provide acute stroke services within the organization boundaries and provide access to the appropriate stroke services. So again, really looking at our, your paramedic prompt, our acute stroke memorandum of understanding and stroke bypass protocol really is key when we identify. It's in red and really identifies what are those high priority standards. Also looking at, does the team have a strategy to raise awareness in the community about the signs and symptoms of stroke, the appropriate actions to take, and how to access acute stroke services? Again, many of you will be aware that most or the majority of the ambulances within our region have the FAST sign on it. That's a way we've collaborated with our partners. Next, we really look at the meat and potatoes of the work that the paramedic services do related to stroke. Really, how do we coordinate with emergency services and ED to develop and coordinate timely services? How do we participate in the ongoing education for EMS providers about their role in assessing and managing stroke clients during the initial assessment and transport? We know that this is a partnership between the paramedic services when there's changes in the prompt card, but also our annual paramedic workshop really allows, from a regional perspective, to say, how can we support that ongoing education? Red is considered a high priority standard, and looking at, do we have protocols, memorandum of understanding with our EMS providers that address our direct transport to stroke facilities, bypass the facilities not resourced to provide immediate diagnosis of stroke, and use of air ambulances for our acute stroke services. This is not only a standard, but it is also a protocol that we need to put forward and have implemented, and really is, what is our EMS bypass redirect? Another high priority standard is that the paramedics will use a standardized valid tool to screen stroke for suspected stroke patients. Again, this is also a protocol related to EMS screening. So key here is sort of the paramedic prompt and the fast screening, also the LAMS score, the LAMS assessment. Next is looking at that the team has a readiness protocol with paramedic services to receive that pre-notification of patients en route. Again, a high priority standard, and also what is that protocol? What is that EMS pre-notification of stroke patients? So again, really looking at that patch process and what's communicated. The team, the EMS and the ED use agreed upon triage levels for suspected stroke patients and communicate those with each other about the client. Another high priority standard is that the team in the ED will initiate stroke protocols when a stroke pre-alert is received from the paramedic services to ensure suspected stroke patients are received efficiently on arrival. So again, what happens when that patch comes? Also a protocol or ED notification of hospital-based teams. Then when we look at is, how does also very high priority, the team responds in a timely manner to ED requests for evaluation of stroke clients to optimize opportunities for time-sensitive care. So really looking at what is that ED swarm? Who meets that patient? Is it the stroke team if they have an internal stroke team? Is it the EDMD who then is, if they're a telestroke site, that really looks and swarms and meets that patient very efficiently on arrival? Also, which is also a high priority standard is, what does the team consult with other services that provide stroke care so that can be rapidly and effectively transitioned to another ED or acute setting to meet their needs? So again, when I think of this from a paramedic services perspective, I think about it for, our EVT patients who are going to our thrombolysis sites for evaluation, who are having their imaging and then are being transferred transferred to the EVT center at Hamilton Health Sciences. Or also, what is our process as someone that presents to our centers are identified as being a hemorrhagic stroke? How do we ensure that timely transfer to the general for neurosurgical care? Next slide, Steph. And I'll turn it over to you.
Thanks, Rhonda. So the next component Accreditation Canada will be evaluating in the process of stroke distinction is reviewing protocols. And so you can see that there are 14 acute care protocols and 6 protocols in rehabilitation. In order to achieve and be successful in stroke distinction, we must achieve 60% of the protocols. And so in acute care, what that means is that we would have to achieve 9 of 14 of these protocols. That being said, I think we strive to have all 14 out of 14 and are well on our way to being fully prepared for this. For acute care, this includes EMS stroke screening protocols, as Rhonda mentioned, the stroke bypass protocol, pre-notification of stroke cases, and as Rhonda mentioned, the ED notification of a hospital-based stroke team. All these elements are covered in our regional acute stroke protocol MOU, and that is in the process of being updated right now, actually. Additionally, Accreditation Canada asks for key quality indicators to be submitted. And so this is data. These are key metrics. These key KQIs, for short, measure the quality of care provided to ischemic stroke clients admitted in acute and rehabilitative care. And so most relevant for the paramedics are the acute care KQIs, and there are 11 of those. And actually for Hamilton Health Sciences as the EVT center, there's actually an additional 2 metrics measured specific to endovascular therapy. These KQIs look at numerous aspects of care, anything ranging from appropriate imaging to expedient administration of thrombolytics to access to stroke unit care in acute settings and transfers to rehabilitation. In stroke distinction, there is a great focus on patient and family education, and super, super important. There are 4 key aspects to achieving appropriate patient and family education, and they include that the client education materials are available and accessible on the stroke unit. The client educational materials are available in a variety of languages appropriate to the client population mix. The client education materials are available in appropriate formats for particularly persons with special communication needs. And this brings us back to our first part of the presentation today, specifically having aphasia-friendly versions of education. And then there's an additional element where, as the surveyors are doing their interviews, the stroke clients and their families would report receiving education regarding their recovery and self-management from the healthcare providers that are caring for them. So there's this really important focus on education that is provided to patients and families, and they also want to make sure that this is documented. And so we've reviewed 4 of the 5 elements of stroke distinction, and one where we actually don't have a slide for is the Excellence in Innovation project. And so we need to demonstrate to Accreditation Canada that we are a leader in excellence in innovation. And so this year we are planning to present to the accreditors for the entire region our utilization of advanced imaging software for the expanded window and endovascular therapy, as we are a leading region with regards to this practice. So this is our stroke distinction journey. This is the map we have been using. And as you can see, we have started our preparation for this earlier this year. Each organization that is going through the distinction process underwent a self-assessment process, reviewing each standard and evaluating the current state within their organization. At that point, each organization then categorized the standards as either met or unmet and developed work plans to address these gaps. As you can see there on the map, by the summer, each organization was starting to work through their work plan and beginning to prepare their staff for next year's survey. Over the past couple of months, the organizations have started to complete mock tracers with their teams, which is mimicking the survey process and asking their teams questions they may receive from the surveyors and providing them with feedback on their approach. The preparation will continue through the winter, by the spring, we'll be into our final phases of site preparation. And the actual survey, we'll get to the dates in just a second, is in May of next year. We fully expect to be very well prepared and ready to go. And it's important to note that the process that has been undergone in the preparation for stroke distinction really has made an impact on stroke care in our region. This has allowed us the opportunity to reflect, self-evaluate, and address any gaps in our stroke system. And so this is really a great thing for us to improve care as we prepare for accreditation. As mentioned, at the end of May is when our survey is. And so it's actually the week of May 26th to the 30th. At that time, there will be 3 surveyors from Accreditation Canada who will come to our region. And the first 3 days of that week, they will be focused in at Hamilton Health Sciences, Grand River Hospital, and the Niagara Falls site of Niagara Health. On the first day, Monday, May the 26th, in the afternoon between 2 and 5 p.m., that is when the surveyors will be doing their tracers, where they will go to the units and meet with stroke care providers in acute care. This will include the emergency department. The surveyors will want to follow the pathway of code stroke patients, meaning they will want to see the parts of the continuum that the patients experience in the different departments that they access. They'll want to speak to members of the team involved in stroke care, so they may stop and ask questions in the emergency department of anybody involved in the care of stroke. These questions will be focused on your very important role in stroke care and protocols for managing stroke patients across our region. I think it's something that, again, we should all feel very comfortable and confident in addressing. It is the best practice work that we do every day. So you might be wondering, what are maybe some of the questions that the surveyor might ask when they're walking through the ED, and they may stop and ask you a question? So we've got some questions listed here. We're running a bit short on time, so maybe just for the first couple, I'll ask for some response from the audience. So please, I can't see the screen, so if you could just come off mute and provide your thoughts on an answer, that would be great. And then we'll run through some further questions. So the first question, how does the paramedic services raise awareness about stroke in the community? So please, anybody, please come off mute, or Tina, if someone adds to the chat, I can't see the chat right now. If you could read it out, that would be great.
I can do that. Now, they won't be able to unmute by themselves. They can raise their hand, and then I can allow them to unmute.
Okay, thank you. Unfortunately, I can't see the audience right now, so if you could help with that, that'd be great. So again, how does the paramedic services raise awareness about stroke in the community?
We've got one in the chat, signage on the ambulances.
Perfect, great example. And Rhonda spoke to it a little bit earlier in the presentation. Yeah, we work very closely as a regional stroke network and paramedic services to ensure that there is great public awareness about how to recognize stroke symptoms, and just as importantly, what to do if you recognize them or recognize them in someone else. And so those fast stickers on the ambulances is a great example of this.
And we also have one more comment, community paramedic program education.
Oh, that's a fantastic one. Absolutely. Getting out there and sharing the information in the community and with folks who may have questions about it is so important. So that's a really great example.
All right, we have a couple more. We have radio
wonderful.
shows and talks and talk about signs and symptoms and response. Also public information departments and spread of information via social media.
Absolutely fantastic. And so actually, I'm thinking back now to, I know there was a representative of the Hamilton Paramedics who was on Cable 14 on a regular basis, sharing important information, and recalling stroke was one of the focuses of those interviews. For sure, getting on the radio, absolutely. And social media, that's a big one. And we do that as a coordinated effort, particularly in June for June Stroke Month. As well as in October for World Stroke Day. Maybe just one last question here, and then I'll just highlight the rest so that we can make sure we get through the presentation before the end of the morning today. So what protocols are in place to promote timely, coordinated stroke care? Same idea, if you either want to raise your hand or just add to the chat.
Okay, here we have regional stroke bypass with direct activation of the stroke team at GRH. And then protocols in ED at triage.
Perfect. So that example came from KW. Thank you so much. And that happens at all of our stroke centers. Absolutely. Our bypass protocols, the MOU that Rhonda spoke to earlier, the processes when getting to the ED, absolutely. So many protocols in place that we really do work together to ensure that there is timely, coordinated, efficient, and effective care for persons with stroke. I think I'm going to just highlight the rest of the questions here just because we're running a little bit low on time. But these are, again, as you can see the examples, these are questions of things that you're doing every day, the best practices for stroke care that you provide every day. There's also maybe some questions about your own experience in terms of ongoing orientation and ongoing education. So what kind of orientation and education do you receive about the management of stroke patients? And so reflecting on opportunities like this where, we have stroke half days or stroke full days of education, the orientation that is provided to you when you begin and on an ongoing basis as a paramedic within the region. Dr. Catanese spoke a great deal about this. What screening tools do you use for suspected stroke patients? Again, sort of going back to what you do every day in terms of best practice management. What is the management of suspected stroke patients in the field? What information do you communicate about stroke patients while en route to the hospital? What triage level do you use for stroke patients? What information do you provide as part of your TOA to the emergency department when you arrive? And what is the process for transferring stroke patients from thrombolysis centers in our region to the EVT center? And so Rhonda spoke a little bit about getting patients from our stroke centers around the region to Hamilton Health Sciences, the general site for EVT. And so what is that process like? So again, things that we're doing every day to enact best practice and ensure that there is a timely, effective, and efficient process and a very coordinated process for hyperacute stroke processes. Rhonda, I'm going to run to start the data component. Anything you wanted to add to this before moving on to the next component?
Yeah, I think just really highlighting, and if the surveyor is asking you any questions, it's really highlighting, your provincial paramedic prompt, really essentially what you do every day with your stroke patients. And we sometimes think of it as commonplace, and really just to recognize that that is best practice, and it is excellent. And so really just if the surveyor is asking you questions, is really just sharing what you're doing every day, and celebrating the amazing work that you do in stroke care from a hyperacute perspective.
Yeah, that's a great way to put it, Rhonda. Feel very confident in being able to speak with the surveyors. They will be, I think, very, very impressed with the incredible work that you do. We use the phrase "gather, not scatter." So if the surveyor is coming along, we love for team members to move towards the surveyor and be ready to answer those questions and have a great discussion with them rather than moving away. So feel very confident as you do amazing work every day in stroke care. Maybe I'll quickly bypass the questions till the end and just quickly start in. Ron and I wanted to share some stroke performance metrics. We know that feedback about stroke care is very important and much sought after by paramedics through our region. And so we want to start to provide some of our data, like we have at previous paramedic workshops, looking at some of the key metrics related to stroke care. So I'll just do a couple of minutes and hand it off to Rhonda. We have a table within our region called the Regional Stroke Monitoring and Evaluation Committee. And at that table, we're able to share data on a quarterly basis with one another. It's a huge advantage within our region as we're able to learn from one another. So just to highlight a few of the components of data here, as this is pulled from that Monitoring and Evaluation Committee table, and it's from the first quarter of 24-25. And so as you can see, the proportion of patients with stroke or TI who arrive at the ED via ambulance ranges in our region between 55%, so just about 55%, to just about 75%. 75% is actually excellent performance in terms of an overall percentage of ambulance arrivals. And we certainly strive to increase this number as an entire region. For the proportion of patients who receive thrombolysis, so how many patients that actually get dropped off with ischemic stroke get thrombolytics, get either TPA or TNK. And so within our region, that ranges anywhere between 11.4% up to 17%. And then also thought it would be good to include those TIA cases who get discharged from the ED, sorry, TIA or stroke cases that are discharged from the ED, and how many get referred to stroke prevention. I think this is really, really important to speak to, specifically because these cases, we know that a person who has a TIA, they're at high risk of stroke. And so it's vitally important to get them from the ED to a stroke prevention clinic right away. And so in our region, you can see those patients discharged with TIA stroke directly from ED. It's between 85 and 97% of them are referred directly to stroke prevention services. This is crucial. And then just to note here in terms of how quickly it happens, just to give you a sense of it, within our region, the top performer for a door to needle time, so when the patient hits the door to the time that they receive thrombolytics, our top performer in the region was 43 minutes. This is something we are continuing to try to improve upon, as the goal from the best practices is to be below 30 minutes. And so we continue to drive towards that. But this clearly shows some really great data from our region and some great performance as an integrated system. Very quickly here, these next two slides are pulled from the IDS, again, looking at Q1 in 24-25. And the way that the IDS breaks down these dashboards is through legacy LIN breakdown. So the first slide here looks at the H&HBB geography. And so in Q1, we see here up in the top left there that about 55% of patients arrive to the ED within 3.5 hours of stroke symptom onset. So this is crucial to get patients as quickly as possible to our stroke centers, obviously. And as mentioned, in terms of referral to stroke prevention clinics, those patients who were discharged directly from the ED, 91% of them were referred to secondary prevention clinics. And looking at the same data from Waterloo Wellington, you can see here in Q1 that 63% of patients arrived within that 3.5-hour window. About 11% received thrombolysis. And then again, about 83% of those patients who were discharged directly from ED were referred to secondary prevention clinics very, very quickly. Apologizing for moving quickly through that data, but certainly wanted to get it to Rhonda to speak to our EVT metrics.
Thanks, Steph. So again, we'll share some metrics with that. Next slide, Steph. Again, we are looking at fiscal year 24-25, so April until June. And what I will share is if you look at sort of the first, from April 1st of 2024 to October 31st, we did about 126 cases of EVT from patients came through the Hamilton General ED and from our regional partners. We anticipate we'll probably be doing approximately about 230 by the end of the fiscal year. What we look at is of all of the ischemic stroke patients who present within our Hamilton catchment area, so in our Central South region, the proportion of patients who receive endovascular treatment is 6.7%, which is just a little bit below our Ontario rate, and really is an area we've been focusing on ensuring that the patients have access to EVT. Also very relevant for the paramedic services that are transferring patients from our regional hospitals to the general. We are the leader in the province of the proportion of patients who are transferred who end up being treated with endovascular therapy. We're at about 78.8%, significantly above the Ontario rate of 63%. Also then looking at, of the patients who undergo endovascular treatment, how many of the cases do we actually open up the artery completely? Again, our rate at the Hamilton General is 92.3, above the Ontario rate of 88%. So really doing very amazing work with our patients. I did say that the proportion of patients who are transferred and treated is high at 78.8, but why are patients who are transferred not treated? So on the next slide, what you can see, and this is pretty consistent that we look, is in blue, about 29% of patients, the reason that they don't get treated when they are transferred to the Hamilton General is that they improve en route. They've received thrombolysis at the referring center. By the time they come to the Hamilton General, either their neurological deficits have improved or resolved, or when they do a CT angiogram, there is no clot in that large vessel occlusion. So again, really there's no need to undergo EVT. About 14.3% of the time, the clot, either because they've received thrombolysis, has moved too far, too distal down the arteries, they're not able to retrieve it. Again, 43% of the time, this is a bit higher than what we've seen in the past, but sometimes is what happens is the stroke's extended too much. And so really, if we were to do endovascular treatment, again, there's too much dead brain, the likelihood of the patient having improvement significantly reduces. Again, there are times where, again, that is the 14.3%. There are some times where, again, when they get to the general, that's the 42.3, where, again, for some reasons, either when they do the angiogram, it's actually felt not to be clot, but maybe it's an ICAD. But again, reasons why we may not see it. But again, really, it's typically because either they've significantly improved, the clots move too distally, or that they have extended their stroke. Next slide, Steph. Just to wrap up at the last, we've been working with the Center for Paramedic Education and Research. We very much hear from our paramedics that we want feedback. I know individually organizations have tried to provide feedback. We've really struggled because of the volume to have a sustainable case-by-case feedback. So we're really trying to work to get that feedback. So we've worked with CPR to get some LAMS data. Twofold with the LAMS, one really to look at understanding the volume of LAMS positive cases in the 0 to 6 hour window, and also in the 6 to 24 hour window, so we can really inform our planning. So next slide. This is data for from April the 1st of 2023 to March the 31st of 2024. This is pulling from the EPCRs. It's pulling patients who have a primary problem of stroke, coded 41, code 41 on your EPCR stroke, and or those that have a LAMS assessment code 20.01 from the EPCRs. And so what you can see is about 55% of patients have a LAMS score that's less than 4, and about 11% of cases have a LAMS of 4 or 5. What we saw in the data, and we're really trying to understand this a bit better, is about 34%, it's unknown if what the LAMS assessment score is. We're moving forward to try and determine, is it because it's not a closed call rule, so that you have to document the LAMS before the EPCR is closed, or is it that it's being documented on a special form that we're not sure? Finally, the other piece of data that we've been looking at is, again, trying to get some data, and you can see Katie was able to pull from 2019 to 2023, and really looking at, did they meet the stroke protocol bypass criteria? Was there no stroke bypass, or was it not documented? And so I'll focus just on 2023. There were 3,823 total suspected cases in our region. Of those, you can see that 1,104 met the stroke protocol criteria, bypass criteria, and about 22 didn't meet the stroke bypass criteria. And then, 500 met the stroke bypass criteria. No, sorry. I wrote it down at 22, there was no, it was not documented if they met the protocol criterion. It may be that they went directly, you're in Brantford, so you go directly to the Brantford General, which is your stroke hospital. You're in Hamilton, you go directly to the Hamilton General. And then there was 500 where there was no stroke bypass. So again, we've just started to get the data on this, and I think we're trying to understand the data a bit more to really create some meaningful data. I'll just move, because I know we are at 12, to see if there's any questions for Steph and I as we move forward. As we wrap up.
Does anyone have any questions that they want to put in the chat or in the Q&A? I want to thank you, Rhonda and Steph, and to the audience for your engagement.